Hi, my name is Hans Lee. I'm an associate professor at MD Anderson Cancer Center in Houston, Texas, in the Department of Lymphoma Myeloma and the Director of Multiple Myeloma Clinical Research. And at this year's ASH 2023 meeting in San Diego, we presented an abstract entitled Clinical Outcomes in Real-World Patients with Triple-Class Exposed Relapsed Refractory Multiple Myeloma, a retrospective study using electronic health records from the Flatiron Health and Coded Vantage databases. So the main rationale of this particular study was to examine the real-world outcomes in patients with relapsed refractory multiple myeloma who are triple-class exposed. And this means that patients have been exposed to the three main pillars of myeloma therapy, including protein inhibitors, immunomodulatory drugs, and anti-CD38 monoclonal antibodies. And until recently, this has been a significant unmet need in the multiple myeloma treatment landscape, because beyond these three main pillars of classes of drugs, there have been very limited options until recently with the advent of BCMA-targeted agents. And so this is important to look at because currently, in order to get the novel BCMA-targeted therapies in a standard care setting, patients must have at least 4 prior lines of therapy. But in the real world, we often notice that patients become triple-class exposed or triple-class refractory before reaching 4 prior lines of therapy. So there still is an unmet need in patients with earlier lines of prior therapy. And so in this particular real-world study, we looked at the de-identified electronic health records from 2 large databases, the Flatiron databases and the Coded Vantage databases, and looked at the outcomes of patients who are triple-class exposed with relapsed refractory multiple myeloma. And so the inclusion criteria from this particular analysis included patients who were diagnosed with multiple myeloma after 2011 and who became triple-class exposed roughly between 2015 and 2021. And we looked at the outcomes in particular of patients who received treatment after becoming triple-class exposed, known as a triple-class exposed index treatment regimen. So in total, there are about 2,500 patients identified who were triple-class exposed between these 2 databases. About 1,700 patients had at least one triple-class exposed index treatment regimen among the 2,500 patients. In this patient group, the median age of patients was about 68 years of age. Approximately 75% of patients were triple-class refractory. And what we found was that in this particular data set, the outcomes of patients who were triple-class exposed, and again, this is largely in the pre-BCMA-targeted era, had poor outcomes, meaning that their progression-free survival was roughly about 5 months or so. Overall survival, depending on the database, was about 22 to 24 months. And the overall response to treatment was about 15%. So when we looked at the treatment regimens that patients received, oftentimes they received treatments that were recycled from drug classes they previously received, including IMiDs, protein inhibitors, and anti-CD38 monoclonal antibodies, as well as alkylating agents. And so in summary, at least in this particular real-world observational study, looking at 2 large electronic healthcare databases, there were limited options for treatment and overall poor outcomes among patients who are triple-class exposed and triple-class refractory, again, largely in the pre-BCMA-targeted era. And notably, patients became triple-class exposed at a median of 3 prior lines of therapy. And so I think the take-home message really is that patients become triple-class exposed and triple-class refractory before 4 prior lines of therapy, and really defining the availability of drugs based on lines of therapy may not be the most optimal way to do things. And so really drug refractoriness and drug exposure status really should dictate, what patients should receive as our next line of therapy. And hopefully these type of data will pave the way for novel therapies to become available for our patients, such as the novel BCMA-targeted therapies.